I have no financial interests or relationships relevant to this presentation. The Eye Pathology Laboratory processes and diagnoses eyes and ocular adnexal specimens, including nucleated globes, eviscerated globes, corneal buttons, biopsies of eyelid conjunctival and orbital tissue, intraocular biopsies, and orbital exoneration specimens. Enucleation is removal of the eye. Evisceration is removal of the intraocular contents. The scleral shell is left behind. Many oculoplastic surgeons favor evisceration because they feel that cosmesis is better after that procedure. Exoneration is removal of the eye and orbital contents, including all or part of the eyelids. Here's a freshly enucleated eye prior to fixation. This photo shows an exoneration specimen where most of the eyelids have been spared. Eyes are enucleated when they are known or suspected to contain intraocular tumors, typically uveal melanomas or retinoblastomas. Hopelessly blind, severely traumatized eyes are removed to prevent sympathetic uveitis, a potentially blinding autoimmune disease that affects both eyes after unilateral trauma. Many eyes that are enucleated are blind and painful. Many of these have neovascular glaucoma or are severely infected. This photo shows a ciliocoroidal malignant melanoma in an adult. This photo shows an infant with an exophytic retinoblastoma. The detached retina is plastered against the back surface of the lens, and a white pupillary reflex or leukocoria is present. Here's another eye with retinoblastoma that was enucleated. Note the long segment of optic nerve attached to the globe. Surgeons should attempt to obtain a long segment of optic nerve because retinoblastoma has a propensity to invade the nerve. This blind, painful eye developed endophthalmitis after a perforating injury. The anterior chamber is flat and a vitreous abscess is present. The retina was totally destroyed by the infection. This severely traumatized eye was a scleral shell filled with blood. Perforating injuries of the globe frequently result in loss of intraocular contents. Sympathetic uveitis is a bilateral granulomatous uveitis that typically occurs after trauma with incarceration of uveal tissue. Severely traumatized eyes that are hopelessly blind should be removed to protect the vision in the fellow eye. Many eyes that are enucleated have neovascular glaucoma. Pathology specimens require fixation. Fixation arrests autolysis and bacterial decomposition. It preserves the cells, proteins, and other tissue constituents. It stabilizes the tissue and enables it to withstand subsequent tissue processing. And it coagulates tissue proteins and other constituents, preventing diffusion and loss. The classic fixative used in eye pathology is formaldehyde, 10% neutral buffered formaldehyde. Eye should be fixed by immersion in a fairly large volume of formaldehyde for 24 hours. The fixative glutaraldehyde is used for electron microscopy. Bouin's solution, which contains picric acid, is used in many surgical pathology departments. It is not used in ophthalmic pathology labs because it hardens the tissue and stains it yellow. Mercury-based fixatives like B5 and Zinkers no longer are used because they are environmental hazards. Remember, saline is not a fixative. If you send a specimen down in saline, be sure to inform the laboratory staff so the specimen is not overlooked and can be properly fixed. A few years ago, we received an eye in saline that had been enucleated in another state a week previously. The specimen smelled terrible when we opened the container, and the tissue was poorly fixed. Formaldehyde is a possible carcinogen. Specimen containers of formaldehyde in the United States require a warning label. Remember, your pathologist is a consultant. You're referring parts of your patient. Communication with your pathologist is important. If you send a patient to a consultant, you typically write them a letter or give them a call on the telephone. With the pathologist, you communicate by adequately filling out the pathology's slip or talk with your pathologist. If you talk to him, he'll be aware of your case, know that you're interested, and you'll probably receive better service. The poorly completed path slip on the left provides no information. The slip on the right provides lots of information and gets a gold star. If the pathologist receives adequate clinical information, he or she may not have to do expensive, unnecessary tests. In the laboratory, we do what's called grossing. This involves orienting the specimens, determining the laterality, measuring, performing a series of measurements on the eye, transilluminating the eye to look for tumor shadows or signs of prior surgery, cutting the eye, examining it under the dissecting microscope carefully, describing what we see, and taking photographs. The specimen is then submitted for sectioning. This diagram shows some of the landmarks that are helpful in orienting an eye. First thing I always look for is the inferior oblique muscle. Both of the oblique muscles insert temporally. Superior oblique muscle has a tendinous insertion. The tendon runs nasally to the trochlea. The inferior oblique muscle lacks a tendon, and its fibers insert directly into the globe. In many eyes, the longitudinal ciliary vessels are a good marker for the horizontal meridian. They are seen as blue lines on both sides of the optic nerve. Another landmark is the fact that the corneal diameter typically is larger than the vertical diameter. The cornea is typically 11 to 12 millimeters horizontally and 10 to 11 millimeters vertically. Most adult eyes are about an inch in diameter and their cornea is about a centimeter in diameter. The temporal sling formed by the oblique muscles is seen in this diagram from Hogan and Alvarado's textbook of ocular histology. And in this photo of an enucleated eye, the tendinous insertion of the superior oblique tendon has parallel white lines. After confirming the laterality of the globe, we perform a series of measurements using a caliper ruler. These include the length of optic nerve attached to the globe and the AP and horizontal and vertical diameters of the globe. The horizontal and vertical diameters of the cornea and the diameter of the pupil also are recorded. The measurements should be recorded in a standardized fashion. The horizontal diameter should be measured before the vertical diameter. The eye is then transilluminated by placing the globe on the surface of a bright light. In this eye, transillumination highlights a peripheral iridectomy and tells us that this eye had prior surgery. Highlighting the location of intraocular tumors is a very important use of transillumination. This photo shows the transillumination shadow cast by a large ciliochoroidal melanoma. In our laboratory, we use a special box to perform transillumination. The eye is placed directly on the surface of a fiber optic illuminator, disclosing another tumor shadow at the equator. The location of the tumor shadow is marked with blue pencil. Eyes are sectioned in a standardized fashion. We cut a short central cylinder called the PO segment. This is called the PO segment because it includes the pupil and optic nerve. The two caps that are cut are called the calottes. Calotte is a French word meaning skull cap. Skull caps worn by ecclesiastics like the Pope are called zucchettos. In our lab, we cut eyes using 1/2 of a double-edged razor blade which is snapped in two. During sectioning, the globe is oriented cornea side down to avoid dislocating the lens, and the cut is started posteriorly near the sheath of the optic nerve. A gentle sewing motion is employed as the cut is extended anteriorly. Eyes should be open so the sections contain the important pathology. You need to maximize the information. Routinely, eyes should be opened horizontally, because horizontal sections include both the pupil, optic nerve, and the macula. Eyes that have undergone prior surgery that have superior limbal wounds should be opened vertically, so the microscopic sections include the wound. Traumatic wounds or ruptures can be located anywhere. The globe should be opened perpendicular to the wound. Sections from eyes enucleated for tumors must also include the tumor. Tumors can be located in any meridian, and the cut should be perpendicular to the main part of the lesion. After sectioning, the eye is examined carefully using a dissecting microscope. With careful examination techniques and experience, you can make a high proportion of the final diagnoses looking with a dissecting microscope. For example, here's an eye that has peripheral anterior synechnias that are evident. There's a pupillary membrane of white fibrous tissue. The lens is cataractous and displaced anteriorly. There is fibrosis of the vitreous forming a cyclitic membrane. The cyclitic membrane stretches from ciliary body to ciliary body behind the lens and produces a tractional ciliochoroidal detachment. The retina is totally detached by tan-colored gelatinous fluid and is discolored orange, suggesting hemosiderosis. Other specimens that we examine in the laboratory include eyelid specimens, eyelid skin, full-thickness eyelid resections, conjunctival and orbital biopsies, and corneal specimens. The corneal specimens include corneal buttons obtained at penetrating keratoplasty, and in recent years an increasing number of Descemet's membrane specimens from patients undergoing DSEK and DMEK procedures for Fuchs dystrophy and other forms of corneal edema. How we process specimens depends on whether we know how the specimen is oriented. When they submit specimens to the laboratory, surgeons can indicate the orientation of specimens by making diagrams or marking the specimens with sutures. Each specimen should be placed in a separate container. Occasionally, a patient will have multiple eyelid lesions like skin tags or papillomas, and the surgeon will put them all in the same container. This can be a real problem if one of the specimens turns out to be an unsuspected malignancy that was incompletely excised. The clinician won't know which of the lesions was the cancer. A specimen that is not oriented, like this ellipse of skin with a tumor, typically will be bisected. We can diagnose a tumor and tell that the margin is involved, but we can't tell which margin is involved because this specimen was not oriented. The same specimen has been oriented by placing a suture on its nasal margin. The pathologist will submit marginal segments and will be able to determine that the temporal margin is involved. In this instance, a very compulsive surgeon applied multiple marking sutures to this lid resection. Here's a classic photo of a basal cell carcinoma of the inferior eyelid. Such specimens typically are removed using a pentagonal full-thickness lid resection. We process such specimens in a specific way to make sure that the tumor has been completely excised. First, we'll mark the margins of the specimen either with ink or blue pencil. In this instance, we'll remove the nasal margin and submit it separately. Then we'll remove the temporal margin and submit it separately. Some people will remove an inferior margin. And then the main portion of the specimen will be sectioned in a bread loaf fashion and totally submitted. Conjunctival specimens are often difficult to deal with. When conjunctival specimens are thrown into fixative, they tend to ball up, making determination of margins quite difficult. Fresh, unfixed specimens of conjunctiva should be spread on the surface of thin cardboard, like the cardboard that sutures are wrapped around. The cardboard is then floated on the surface of the fixative. The specimen fixes as a sheet as it sinks into the formaldehyde. It is often quite difficult for the pathologist to margin conjunctival specimens in the laboratory. Surgeons should consider submitting separate marginal specimens of conjunctival lesions. Here's an example. This was a case of conjunctival intraepithelial neoplasia that was not placed on cardboard. We can make the diagnosis, but we can't determine if the lesion has been completely excised. Here's an example of a melanocytic lesion of the conjunctiva that was placed on cardboard and fixed as a sheet. The inset shows a squamous cell carcinoma of the conjunctiva that was fixed as a sheet. We can make the diagnosis and determine that one of the margins is involved. The preparation of microscopic sections requires tissue processing. This involves dehydration, clearing, infiltration with paraffin wax, embedding with additional paraffin, cutting the specimen, staining, and cover slipping. The first step is dehydration. Tissue contains a lot of water, and we have to get it into a block of wax. Water and wax are not miscible, so we have to get rid of the water and dehydrate the specimen. We dehydrate the specimen by passing it through increasing concentrations of ethanol into absolute ethanol, which is miscible with xylene, which is miscible with paraffin wax. There are actually machines that do this automatically. This is the tissue processor we have in our laboratory. This shows the different changes of solutions used in tissue processing. Peel Away is the brand name of the paraffin. A specimen is then embedded, it's put in a mold, and wax is injected. And here's the tissue in the block of wax. This is put in a microtome, and very thin sections are cut, maybe 5 to 7 microns in thickness. The ribbon of sections is floated on the surface of a heated water bath, which allows the wax around the sections to expand. The individual sections are separated and picked up on a glass slide. The sections subsequently are deparaffinized, stained, and cover slipped. Now this shows an unstained eye specimen. Now there's enough endogenous pigment in the eye that we can tell that this is from the posterior segment. There's the retinal pigment epithelium and underlying choroidal melanocytes. The retina's there, but we really can't see it because it's unstained. However, histologic staining greatly facilitates our assessment and diagnosis of tissues. In our laboratory, we have an automatic staining machine. And the classic stain that we use in pathology is H&E, or hematoxylin and eosin. Hematoxylin is a natural stain derived from a tree called logwood. It sort of looks like red wine. Hematoxylin is a basic stain, and it stains acids. This is a section stained only with hematoxylin. The hematoxylin is staining the nuclei of the cells in the retina because they contain DNA, an acid. So hematoxylin, a basic stain, stains acidic structures like nuclear DNA. It stains blue or basophilic lesions, cells with scant cytoplasm. Things that typically are basophilic or blue include retinoblastoma, basal cell carcinomas or lymphoid infiltrates. Inflammatory cells, bacterial colonies, and calcium and band keratopathy typically are also blue. Here at the top left is a hypopyon, lymphoma, top right, basal cell carcinoma, bottom left, and basophilic stippling of Bowman's layer in a patient with calcific band keratopathy. This is eosin. This looks like what runs down your patient's face after you put fluorescein in for Goldman tonometry. Well, that's not surprising because eosin is a tetrabromofluorescein. Here's the same section stained with just eosin. Eosin is an acidic dye that stains many basic structures, including many proteins. It stains cells with abundant quantities of cytoplasm. Eosinophilic lesions composed of cells with abundant cytoplasm include squamous cell carcinoma and epithelioid histiocytes. Collagen and other extracellular matrix materials, protein-rich subretinal fluid, pseudoexfoliation, and amyloid are all eosinophilic. This montage of eosinophilic lesions shows a squamous cell carcinoma at top left, epithelioid histiocytes and a sarcoid granuloma at top right, sheets of eosinophilic fibrin in a case of ligneous conjunctivitis at bottom left, and Bisacca deposits of exfoliation material on the anterior lens capsule at bottom right. Periodic acid shift, or PAS, is another stain that's commonly used in ophthalmic pathology. PAS stains unsubstituted vicinal glycol groups. These are oxidized to dialdehydes by the periodic acid, and Schiff reagent, or leukofuchsin, reacts with the aldehydes to form red or magenta complexes. PAS is used to stain the eye's thick basement membranes like Descemet's membrane and the lens capsule. It is used to highlight other basement membranes, cuticular drusen, glycogen, some mucins like the contents of conjunctival goblet cells, and also stains many yeast and fungi. Here's a photo showing the anterior lens capsule stained with PAS. Here's an example of guttate excrescences on Descemet's membrane in a patient with Fuchs dystrophy. Frozen sections. The most common indication for frozen section diagnosis is determination if the surgical margins are free when a malignant tumor is excised. Frozen sections can also be used to determine if tissue is adequate or representative for diagnosis, especially when an invasive procedure like orbital biopsy is done. A picture is worth 1,000 words. This is a specimen submitted for frozen section diagnosis by one of our oculoplastic surgeons. It's immediately evident that this is a biopsy of the right lower eyelid. During frozen section diagnosis, a metal stub is covered with tissue embedding medium. The fresh tissue is placed on the stub and covered with more medium. The tissue is flash frozen using liquid nitrogen or refrigerated isopentane. This shows a specimen after it's been frozen. The specimen is sectioned in a refrigerated microtome called a cryostat. The sections are then stained rapidly with H&E. The major advantage of frozen section diagnosis is speed, and speed has its price. The quality of frozen sections is definitely poorer than permanent sections. Here's a frozen section of a malignant tumor. We suspect that this might be a malignant lymphoma, but we certainly get a lot better information by looking at the paraffin section. Actually, in this case, additional immunohistochemical stains were necessary to make the diagnosis. Remember, lesions that are difficult to diagnose in permanent sections, for example, melanocytic lesions, may be impossible to diagnose in frozen sections. Submitting tissue for frozen section diagnosis may destroy valuable tissue that could give important information if it were processed routinely. Never exonerate an orbit based on frozen sections. Always wait for the results of the permanent sections. In ophthalmic surgery, the ability to tell the patient the diagnosis at the end of the case should never be an indication for frozen section diagnosis. Histochemical special stains use chemical reactions to disclose tissue components. These include special stains for microorganisms, like the tissue gram stain, Brown and Bren, the gamorreomethenamine silver, a GMS stain, a silver impregnation stain for fungus, stains for acid-fast organisms like the Phyte or Ziehl-Neelsen stains, and other silver stains like the Dieterle and Warthin-Starry stains that are used for spirochetes and Bartonella. This is a gram stain showing gram-positive bacteria in the case of endophthalmitis. This gram stain shows colonies of P. acnes entrapped in the lens capsular bag in a patient with postoperative localized endophthalmitis. This is the GMS stain for fungus. The silver impregnation stain stains the hyphae black, and there is a green counter stain. This acid-fast stain shows a large colony of atypical mycobacteria in the corneal stroma. Chalazions are lipogranulomas. They have empty lipid vacuoles surrounded by epithelioid histiocytes. We received this interesting specimen several years ago. The patient had inflammation that failed to resolve after a laser blepharoplasty. Higher magnification looks like a chalazion, with empty lipid vacuoles surrounded by epithelioid cells. Because the history was unusual and the surgeon was concerned, we ordered special
Found
scans.
out that the empty lipid vacuoles weren't empty.
They were chock full with atypical mycobacteria. This Wortham Starry silver stain shows clumps of Bartonella in a patient with cat scratch disease. Other special histochemical stains include the iron stain,
Masson trichrome, stains for mucopolysaccharides, the Congo red stain for amyloid, Weerhoff van Giesen for elastic tissue. We also bleach sections to get rid of melanin. There's a silver stain called the bodium for axons, and Luxol Fax blue for myelin, and oil red O used to be used commonly for fat.
This iron stain shows iron in the corneal epithelium in a patient with keratoconus who has a Fleischer ring surrounding the apex of the cone. This iron stain shows iron in hemosiderin-laden macrophages in a case of chronic vitreous hemorrhage. In this case of hemosiderosis, iron deposited in the ciliary body epithelium is disclosed by the iron stain.
Is an example of a siderotic cataract from a retained iron foreign body. The H&E is shown above, sort of brownish discoloration. The iron
in the epithelium is disclosed below by the intense blue staining.
Masson trichrome stains collagen blue and cells red. This was an interesting case. Under higher magnification, we see these little square deposits within the epithelium.
These were crystals of immunoglobulin, and the patient was found to have Waldenstrom macroglobulinemia. Masson trichrome classically is used to diagnose granular corneal dystrophy. The deposit of abnormal TGFBI protein and the stroma have crunchy margins, and they stain intensely red with the Masson trichrome stain. In this photo, the colloidal iron stain for mucopolysaccharide is used to confirm the diagnosis of macular corneal dystrophy. The material which stains, which is a non-sulfated form of the proteoglycan keratan sulfate, is seen beneath the epithelium, within keratocytes, and within endothelial cells. Small guttate excrescences can occur on Descemet's membrane in macular dystrophy. This colloidal iron stain shows abundant quantities of acid mucopolysaccharide in an adenoma of the non-pigmented ciliary epithelium. Pre-treatment with hyaluronidase abolishes the staining for mucopolysaccharide, indicating that the material is hyaluronic acid. In this case, the Alcian blue stain confirms that a choroidal metastasis is a mucin-secreting adenocarcinoma.
This is a case of secondary amyloidosis beneath the corneal epithelium, stains intensely with the Congo red stain for amyloid.
When the specimen is viewed with polarization microscopy, the amyloid exhibits a characteristic apple-green birefringence. In lattice corneal dystrophy, deposits of abnormal TGFBI protein form linear deposits of amyloid. These stain with Congo red and also show characteristic apple-green birefringence.
Amyloid also shows dichroism. Dichroism means two colors. Here we see a band of amyloid beneath the corneal epithelium. A part of it is orange and part of it is green. We rotate our polarizer, and the green parts turn orange and the orange parts turn green. So this is the dichroism.
In this photo, the Weerhoff van Giesen elastic stain discloses the internal elastic lamina in a temporal artery biopsy. The Weerhoff van Giesen stain is also used to stain the elastotic degeneration that occurs in pinguecula and pterygia. This shows a characteristic vermiform degeneration of collagen seen in such cases. This is the alizarin red stain for calcium, demonstrating calcification within a retinoblastoma.
The von Casa stain for calcium actually stains anions associated with the calcium. The later esterase stain for granulocytic or myeloid sarcoma has been largely replaced by immunohistochemical stains, which are more specific. The R-Red-O stain was used to confirm the diagnosis of sebaceous carcinoma by demonstrating intracytoplasmic lipid. The R-Red-O had to be performed on frozen section tissue because the fat was dissolved out by the solvents used in tissue processing. R-Red-O has largely been supplanted in the diagnosis of sebaceous carcinoma by an immunohistochemical stain called adipofillin that stains proteins associated with fat and can be used on paraffin-embedded tissue. The final part of this lecture discussed immunohistochemistry and newly available molecular genetic tools that are revolutionizing diagnostic ocular histopathology. Immunohistochemistry is a valuable adjunct that greatly facilitates and improves the accuracy of diagnosis in ocular histopathology. At Wills, immunohistochemistry is used most often in the assessment and classification of lymphoid tumors and pigmented lesions of the conjunctiva. Immunohistochemical stains that typically are performed on lymphoid lesions include B-cell markers CD20, T-cell markers CD3 and CD5, follicular lymphoma marker CD10, and CD21, CD23, BCL2, and BCL1 or cyclin D1. Almost all lymphoid neoplasms of the conjunctiva and ocular adnexa are B-cell tumors that stain positively with CD20. A large percentage of ocular adnexal lymphoid lesions are extramarginal zone lymphomas of mucosa-associated lymphoid tissue, or MALT lymphomas. Most of the small lymphocytes in a MALT lymphoma stain positively for CD20 and are negative for CD10. A small number of T cells that show similar staining with CD3 and CD5 are present. Mantle cell lymphoma comprises about 2 to 7% of ocular adnexal lymphomas. Mantle cells has a poor prognosis and frequently is widely disseminated at presentation. The nuclei in this case are larger and mitotic figures are present. In mantle cell lymphoma, the tumor cells co-express B-cell marker CD20 and T-cell marker CD5, but don't co-express CD3. The tumor cells also express BCL1 or cyclin D1. In this follicular lymphoma, the cells comprising the large neoplastic follicles stained with CD20, follicular center marker CD10, and are also positive for anti-apoptotic protein BCL2. BCL2 is negative in normal germinal centers. Immunohistochemistry is commonly used to assess pigmented lesions of the conjunctiva, including nevi, melanomas, and acquired melanosis. Immunohistochemical stains used for conjunctival lesions include melanocytic markers Melan-A and SOX10, HMB45, and proliferation marker Ki67. SOX10 and Melan-A used with a red chromogen readily disclose the number and location of melanocytes within the epithelium and are also used to confirm the presence of invasive melanoma. HMB45 stains melanoma cells, and Ki67 highlights the number of cyclin cells, which is increased in melanoma and typically is low in nevi. This montage shows a conjunctival melanoma arising from a nevus. Both the nevus and melanoma are intensely immunoreactive for Melan-A, but only the melanoma at right stains with HMB45 and shows cellular cycling with Ki67. In our lab, immunohistochemistry is used infrequently in the diagnosis of intraocular tumors. Most intraocular tumors and melanomas are retinoblastomas, and the diagnosis usually is obvious and immunohistochemistry is unnecessary. Immuno is used in rare cases like uveal leiomyomas or schwannomas. In this leiomyoma, the smooth muscle nature of the tumor is identified by positive staining for smooth muscle actin. Immuno is also used to identify primary tumors that have spawned intraocular metastases, like this metastatic breast carcinoma, which is immunoreactive for breast marker BRST1. Immuno is used to assess a variety of primary and metastatic orbital and adnexal tumors. The diagnosis of orbital rhabdomyosarcoma is confirmed using immunohistochemical stains for muscle markers like myogenin or muscle-specific actin. Immuno is also used to assess well-differentiated sebaceous neoplasms for abnormalities in DNA mismatch repair proteins, which are found in the Muir-Torre syndrome. Other tests based on molecular genetics are becoming increasingly important in diagnosis. These include the presence of characteristic gene amplifications, like the MDM2 amplification found in atypical lymphomatous tumors, and translocations. Detection may require special procedures like fluorescence in situ hybridization, or PCR. Diagnostic chromosomal translocations and resulting fusion genes and fusion proteins occur in specific cancers and can be used to diagnose them. Most alveolar rhabdomyosarcomas have specific gene translocations and result in fusion proteins that involve the FOXC01 and the PAX3 or PAX7 genes. These translocations serve to differentiate alveolar rhabdo, which has a poorer prognosis, from embryonal rhabdo. Not all cases of alveolar rhabdo have an alveolar appearance on routine histopathology. These translocations are important prognostic indicators. Patients with a PAX3 FOXC01 fusion often have a significantly poorer outcome than patients with the PAX7 fusion, with 4-year survival rates of 8% and 75% respectively. Some fusion proteins can be detected with immunohistochemistry. For example, nuclear staining with the STAT6 immunostain is used to diagnose solitary fibrous tumor. This stain detects a characteristic fusion protein between the MNAB2 and the STAT6 genes. Immunohistochemical stains for fusion proteins are also used to diagnose pleomorphic adenoma and adenoid cystic carcinoma. Some of the ocular and adnexal lesions that have characteristic fusion proteins are seen in this slide and the following slide. Important molecular markers for prognosis in uveal melanoma include non-random chromosomal abnormalities, such as monosomy 3, and gene expression profiling, which has identified several classes of uveal melanoma that differ markedly in their behavior and prognosis. Inactivating mutations in the BAP1 gene, which predispose to metastasis, are found in 84% of class 2 melanomas. An immunostain is available to detect this mutation. Finally, immunohistochemistry is also used to detect expression of programmed death ligands such as PD-L1 and PD-L2 in ocular tumors and determine if they may respond to therapy with immune checkpoint inhibitors. Thank you.